These are my disclosures. So first, as we talk about myeloproliferative neoplasms, let's talk a little bit about the goals in these diseases as well as the targets. So the myeloproliferative neoplasms, we're going to speak really today about 3 diseases that are interrelated. They're chronic leukemias. They include essential thrombocythemia, polycythemia vera, and myelofibrosis. And these in aggregate represent about roughly 450,000 patients in the US. I like to tell individuals they're not common diseases, but nor are they rare. You know, they're not an atypical HUS or other diseases that really are quite uncommon. There are plenty of patients out there that unfortunately labor against these diseases. Indeed, I was at a clinic today and saw 10 new patients with MPNs just today alone, ranging today from a 15-year-old with ET to a 91-year-old with polycythemia vera. Now, given they're a very heterogeneous group of diseases, we've given a lot of thought to try to understand, how are the patients afflicted? And indeed, there's a range of ways that they burden the patient that faces them. One, they can have risk of vascular events. They can have risk of thrombosis or bleeding. That's more common in P. vera and ET, but it can happen in myelofibrosis. They can have risk of cytopenias, with anemia being much more common in patients with myelofibrosis. They can have splenomegaly that is predominant in myelofibrosis, but it can be present in ET or PV. They can have difficult disease-associated symptoms in all 3 of the diseases. We believe these symptoms are tied to the biology of the disease. And they can have risk of progression from early MPN, PV, or ET into myelofibrosis. They can go from myelofibrosis to AML. Indeed, as I visit with patients, as I have this discussion with them today, for most individuals who are diagnosed with an MPN, it is progression which is the greatest risk. Because for most individuals, if they are managed, they would live out their normal lifespan if the disease did not progress. Now, all of these things occur in the setting of a person that brings to the table their age, their comorbidities, their level of fitness, and their own individual wishes and desires as it relates to their healthcare and goals in life. Now, let's begin with discussing both the current therapy as well as evolving new options for the earlier MPNs, ET and PV. These are the most common of the MPNs. In aggregate, this represents probably 300 to 400,000 individuals in the United States. Now, the incidence is not super high, new patients per year, but the prevalence is quite a bit higher as a reflection that many of these individuals, fortunately, will live out their normal lifespan. ET in aggregate does shorten the lifespan as an aggregate whole, but modestly so. With polycythemia vera, it is more definitive. So let's first start with ET. Now, I bring up a couple slides from the NCCN treatment guidelines. Indeed, I partnered with other colleagues to try to bring some uniformity to how we address MPNs in the United States by creating these guidelines. I think NCCN provides a great service. It provides some great, I think, consistency and uniformity of approach across a US practice, particularly with diseases like this. So with ET, one, we primarily, let's start with high risk, because this is a group that we primarily utilize medical therapy. There's a few key things I would point out here. So one, these are individuals with high platelets. They have risk of thrombosis or bleeding. Maybe they've already had thrombosis or bleeding. We want to first manage cardiovascular risk factors. We consider low-dose aspirin. There's some data on low-dose aspirin twice a day. And our initial preferred regimens to try to normalize the platelet count under 400,000, control leukocytosis if present, is either hydroxyurea or long-acting interferon, such as pegylated interferon. Finally, anagrelide can be considered. In my own practice, I find anagrelide is a helpful therapy, but usually in combination with a second therapy. There are not many patients that tolerate high-dose anagrelide. Then as you're treating them, you're aiming to get the counts into control. And you're monitoring for many things. Are they tolerating the medicine well? Are they not having vascular events? Are the counts in the goal range that you have? If so, continue. If not, we consider a second-line therapy or both in an investigator-initiated study, which is at my center, as well as a broader international study. Here, with these individuals, this medicine is impacting inflammatory cytokines and impacting growth factors. Now, in data from this year's American Society of Hematology meeting in December in Atlanta, we saw that the data from the phase 2 study was presented. This in a European study, this showing aggregate data, but showing a very nice decreased control in the platelet count in individuals that had failed one or more lines of therapy, including hydroxyurea. And this showed, again, almost universal response again across these individuals. Similarly, we've had good results in our investigator-initiated study in San Antonio. Next agent I would highlight, so backing up just a bit. So these data are leading to a phase 3 global study that'll be opening up soon for bomedemstat in patients with ET. There is an ongoing global phase 3 study in ET. This is with ropegylated interferon alpha 2b. We're going to discuss this agent in the context of polycythemia vera, where it has recently been approved. Dr. Serge Verstavchik and I, Serge Verstavchik from MD Anderson in Houston, are leading this global study for second-line therapy in patients with ET with leukocytosis, ropegylated interferon alpha 2b versus anagrelide. So this is continuing to accrue, but if you have patients that sound that they fall into that category, please consider referral to one of the sites. Polycythemia vera is very similar to ET in many ways, but one critical way that it is different includes the presence of erythrocytosis. So again, we manage cardiovascular risk factors. And I'd say do so aggressively. There have been studies that have been done that if you were to take an MPN patient with cardiovascular disease and they see a cardiologist, the cardiologist really controls the cardiovascular risk factors and is not overly mindful of the blood counts. You flip it around, if they see a hematologist, we control their blood counts, but we're not very picky about their cholesterol. Truly, both things need to be controlled. Diabetes, smoking cessation, aggressive control of hypercholesterolemia, exercise, diet, these things are important. Aspirin, of course, just like the discussion in ET, and there's randomized data showing the benefit of low-dose aspirin in these individuals. Now, a critical additional step is the control of hematocrit, to maintain a hematocrit under 45%. Now, in the past, this was a bit lax. People would come in, their hematocrit was 48, you'd say, well, we'll check it again in a month. We now recognize from randomized studies that controlling the hematocrit under 45, having 45 as a ceiling, is important. There was a study done in Italy that hematocrits of 45 to 50 were associated with significantly higher rates of thrombosis. So if it's 45.1, do a phlebotomy. If it's hanging around 45, they probably need tighter control of disease with either better cytoreductive therapy, higher dose, or another approach. Now, in high-risk disease, we use frontline therapy, and you'll notice that the frontline therapy is the same as the frontline therapy we consider in ET, hydroxyurea or pegylated interferon. And as we're monitoring the disease, we're monitoring it in a very similar way. ET and PV are very much kissing cousins of one another, with the hematocrit really being the significant difference. Now, as they start on cytoreduction, it's critical to see, well, did you achieve your goal? So things that would lead you to consider second-line therapy is one, obviously, if you don't achieve your goal with the first-line therapy. It's not uncommon to have someone on hydroxyurea, but on a dose that is insufficient to adequately control their counts. You got to control their counts. Are they not having thrombosis or bleeding? Are they needing ongoing phlebotomies? Do they have splenomegaly? Are the counts going up, or do they have difficult to control symptoms? If the answer to any of these is yes, then we need to consider a change. Is that a higher dose of medication or a different medication? Now, unlike in ET, there is an FDA-approved therapy in the second-line setting for vera, specifically ruxolitinib. So we'll get around to discussing that in myelofibrosis, but it is a clear therapy in the second line for vera. Additionally, if you had started with hydrea or interferon, one can consider switching to one of the other two. But my preference, if I'm going to second line, is probably to go to ruxolitinib, as it has the greatest data in this second line setting. Now, there is a new interferon that has become on the market for US patients and now globally, ropegylated interferon alpha 2B. These are data straight from the EHA meeting just a few days ago, showing long-term results from the definitive study that led to the approval of the ropegylated interferon. They followed for a long period of time patients with ropeg versus hydroxyurea, and then a continuation study that included crossover. What they showed over time was significant superiority for both complete hematologic response as well as molecular response for ropegylated interferon alpha versus the control group. And why this matters is molecular response may well be associated with event-free survival, and complete hematologic response associated with improvement in risk of thrombosis or bleeding and symptomatic improvement. This showing here, again, clear superiority as it relates to hematocrit control well into, deep into the study, 4 or 5 years in, showing better durable control. Additionally, a very significant difference as it related to the percentage of patients that achieved a JAK2 allele burden less than 1%. So we believe a deep level of control. Now, on this slide that I think was one of the most interesting slides from EHA 2022 as it related to MPNs, was showing the event-free survival of individuals that went on ropeg versus the control arm. And this is highly significant. This is risk of death, disease progression, and thromboembolic events. Again, showing even though in our NCCN guidelines, we had hydroxyurea and interferon as interchangeable options, this increasingly showing the attractiveness of ropegylated interferon for these individuals. Now, it was in November of 2021 when ropeg became approved, now with the trade name of Bezreni from the producers Pharmacentia in the US and AOP Orphan in Europe. This agent, like the interferons, has potential side effects, as all medicines do. Very specifically, it can cause flu-like symptoms, it can cause cytopenias, increased liver function tests, rare autoimmune diseases, or depression. Do you think that the issue of dose is important? We typically start people at a low dose and monitor for these things. Overall, I find that the majority of patients tolerate interferons well, but not 100%. You need to be mindful with these therapies. Now, how one begins on this therapy, it's a dose titration. If not already on hydroxyurea, they begin on 100 micrograms every 2 weeks of Ropeg up to a max of 500. I'd say most patients are probably going to end up somewhere here in the middle. And if you're transitioning from hydroxyurea, you start them a little bit lower, tapering the hydrea. And again, you might get up into this range, but in my experience, as background, the rationale is to use a hepcidin mimetic to recreate the phenomenon of anemia of chronic disease to control erythrocytosis in polycythemia vera, with its potential advantage being to decrease the red cells without cell destruction and also without the need for iron deficiency. Indeed, phlebotomy works by creating a state of iron deficiency that may aggravate symptoms of the disease, such as fatigue, restless leg syndrome, or other difficulties, shortness of breath. There's a trial done that was presented by my colleague, Dr. Ron Hoffman, the REVIVE trial, where again, there was a clinically effective dose finding phase, and then an evaluation phase, a randomized withdrawal phase, and an open label extension phase. What you see here nicely is that with, on the left, individuals only receiving phlebotomy, or on the right, phlebotomy and cytoreductive therapy, you see good control of the hematocrit with the use of rusfertide. Indeed, during the first 28 weeks of treatment, 84% of patients did not require a phlebotomy, and there were phlebotomy requiring entering the study. So it made really a very significant difference. Not unexpectedly, the agent was very specific for the red cells. So it did not significantly change the white cells or the platelets. This is not a therapy that necessarily is going to replace interferon for high-risk disease with elevation in all 3 counts. This is a drug that may help to better control hematocrit in individuals that are only requiring phlebotomies in lower risk disease. It may be a therapy that may be helpful to add on in addition to cytoreductive therapy for individuals that are already on cytoreduction. As was hoped, there is an improvement in iron stores and improvement in MPN or PV related symptoms that may be worsened by a phlebotomy or iron deficiency. So you see here improvement in concentration. Side effects, again, all things have side effects, and you see here, again, there may be some injection site reaction. That was by far the most common. There have been no grade 3 related effects related to the drug. And again, here you see a range of GI, headache, some pruritus, and other difficulties. This is currently, there's an enrolling double-blind placebo-controlled study called Verify for these individuals. They're on their ongoing therapy and either plus rusfertide or placebo. So patients, again, they're all getting therapy that they would have gotten anyway and trying to demonstrate the incremental benefit. So a good study, patients are not being denied the therapy that they would have received. Certainly would have you consider this if you have appropriate patients. Now let's pivot toward myelofibrosis. Myelofibrosis is the most severe of the MPNs, the most likely to cause premature mortality and morbidity. So it is natural that many agents have begun their testing in myelofibrosis before evolving to eventually be in polycythemia vera or essential thrombocythemia. I've used the story a couple of times this year. It's now been about 30 years since I saw my first myelofibrosis patient as a first-year medical student at Mayo Clinic in Rochester, Minnesota. And that patient, it was very tragic. She was a young woman. She was from Venezuela. She was in her early 30s. She had a massive spleen. She had a splenectomy because we didn't really have much else to do to help the disease in those days. She died of splenectomy-related complications only a few days after I first saw her, working alongside my mentor at the time, Dr. Myelodysplastic. That got me very interested in these diseases, trying to understand why such a significant burden. We were involved in many clinical trials, and in the first 15 years of my career, we really did not make a lot of progress. We were trying to beg, borrow, and steal drugs from other indications, usually without a lot of success. It was in 2005 that the discovery of the JAK2 V617F mutation was a watershed moment, both in, I think, recruiting additional scientists to study the disease and try to expand our knowledge, but also to energize partners in the pharmaceutical industry to find, now that there were potentially druggable targets, ways to specifically try to help MPN patients. Since that time, we have now seen the approval of 3 drugs in myelofibrosis and several others on the cusp of approval. Ruxolitinib, fedratinib, and now pacritinib, most recently approved. And closest on the horizon, myelodysplastic, as well as ruxolitinib combinations. There have been many agents that have come and gone that were tested, and either due to toxicity or the competitiveness of the field are no longer in development. Ruxolitinib was the first of these and really became a cornerstone therapy for these diseases. It's made a huge impact. Approved in November 16 of 2011, approved on the basis of the phase 3 trial that Serge Verstavchik and I led in North America of ruxolitinib versus placebo, and the European study led by colleagues of ruxolitinib versus best alternative therapy. And this showed significant improvement in splenomegaly and symptoms, clearly and vastly superior to placebo or best alternative therapy. Now, over time, we have seen another very important observation, and that is an improvement in survival. The trials were not designed as survival studies. However, it became fairly clear relatively early on that patients lived longer. They lived better, but they also lived longer. And that the length of life seemed to not be easily explained solely by improvement in debilitation, greater levels of energy, all of which were things that they had. They had decreases in splenomegaly, but we didn't really think that the decrease in the mechanical effect of the spleen really was mechanistically the reason for improvement in survival. These are nice data that were gathered by our colleagues at MD Anderson that showed not only a decade improvement in survival, but really tying it with the exposure to ruxolitinib. Why is this the case? I think it's multifactorial. I think there may be less inflammation. I think there may be a less toxic bone marrow microenvironment, less likelihood of progression toward acute leukemia. There's not a plateau, so it does not cure the disease, but the impact is real. Indeed, I saw in January of this year a patient that had gone on the COMFORT study back in 2009, and now coming to see me in 2022. I went back and calculated, well, what would have been the individual's prognosis if we had looked back in 2009? And their estimated survival by the DIPSS at that point was under 3 years. And here it was almost 13 years, still on ruxolitinib. Now, the patient was coming off of ruxolitinib, they were now having some evidence of progression, and we put them on a clinical trial. But their survival was 4 times longer than it would have been otherwise. So a very significant advance, but still room for us to grow. Now, a couple important lessons we have learned over time. One, the dose of ruxolitinib you use matters. There's probably too much underdosing of ruxolitinib in the United States. You have to use a sufficient dose if you're going to have an expectation of improvement in survival. Ideally, 15 milligrams twice a day or more. Fedratinib, now approved since August of 2019. This is also a JAK2 inhibitor, such as ruxolitinib. It's a FLT3 inhibitor. It was approved on the basis of 2 trials, the Jakarta study, which was the upfront study compared to placebo, and the Jakarta 2 study, a second-line study that I led along with Professor Harrison from the UK. The Jakarta study with 2 different doses of fedratinib, the 400 milligrams now being the FDA-approved dose, versus placebo with the potential of crossover, with improvement of splenomegaly or symptoms as the goal endpoints. What was seen was clearly fedratinib was vastly superior to placebo alone. The 400 milligram dose was chosen because it was the best combination of efficacy, and it was a better tolerated dose than 500. 500, you might get a little bit more of efficacy, but you gain a lot more in terms of side effects. So what side effects? One, there are common and then there are rare. It can cause cytopenias, as can ruxolitinib. On the rare side, there was a small number of individuals that developed a neurologic event that appeared to be like Wernicke's encephalopathy. Over time, thiamine levels were found to decrease in these individuals. It's unclear whether those initial individuals really had Wernicke's encephalopathy. But on an abundance of caution, the FDA had put the drug on a hold and now approved, but with a black box warning, monitoring for Wernicke's replacement of thiamine. Much more common side effects. It can cause some GI side effects. This is a bit incremental compared to ruxolitinib, and typically do begin patients with either antidiarrheals or anti-nausea drugs to avoid or to control these side effects. So if I'm using fedratinib in the front line or in the second line setting, I'll start at 400 milligrams a day, assess thiamine levels in alignment with the FDA black box guidance, replace thiamine if it's low. I'll start them on fedratinib, give them PRN, nausea, or antidiarrheal medicines. I'll be honest, in my practice, I still typically give them thiamine. Thiamine's cheap, really aren't a lot of downside. I give them 100 milligrams. You get 100 pills at CVS for like $9. Not a lot of downside. And then we monitor response, monitor for GI toxicity. Usually those GI concomitant meds can be discontinued, and we'll continue them on thiamine. There were updated data regarding the FREEDOM study. The FREEDOM study is an additional kind of post-approval study in fedratinib, monitoring thiamine, giving thiamine, and both that with the GI prophylaxis, patients are able to tolerate the drug, they're staying on the drug, and we're not seeing any episodes of Wernicke's encephalopathy in patients appropriately treated. Jakarta 2 was the second line study that again showed benefit in individuals that failed ruxolitinib. These were updated data that I presented in a series of meetings over 2020 and 2021, and is a helpful backup option. In 2022, if a patient has failed ruxolitinib, fedratinib should be your preferred option as second-line therapy for an individual with a platelet count of over 50,000, especially if they do not have access to a clinical trial. Fedratinib, approved the most recent at February 28th of 2022. Now, this drug is a little bit different spectrum of action and a little bit different set of patients. These are more these cytopenic patients with myelofibrosis, lower counts. They tend to more often have primary myelofibrosis. They tend to be JAK2 negative. They have a higher risk of acute leukemia. This is a JAK inhibitor, but it's also an IRAK1 inhibitor that may change its spectrum of activity and may allow it to be more successful in this subgroup of patients. In studies, it has been seen. This were the PERSIST-2 study for patients with a platelet count of under 100,000, showing improvement at 200 milligrams twice a day compared to either ruxolitinib or once a day for control of splenomegaly and of symptoms. And indeed, the 200 milligrams twice a day is the recommended dose. As one would expect, the platelet count was stable for these individuals to improving. Again, it's not a platelet therapy. What this allows is the ability to use this medicine in individuals with a platelet, irrespective of platelet count, but that it is safe for individuals with a platelet count of under 50,000. And as such, it is unique amongst MPN therapies and having been tested in this group of patients and found to be safe. There also can be improvements in anemia. And again, here data from my good friend and colleague, Jan Mascarenhas, showing improvement in rates of transfusions. Side effects, again, GI-related side effects, so it overlaps a bit with fedratinib in that setting, as well as can cause cytopenias. This too now is approved, here showing the FDA label with its trade name of Vonjo, 200 milligrams twice a day, with or without food. It is for platelets, individuals with myelofibrosis with a platelet count of under 50,000, whether that be frontline or second line. Now, there are not many patients that are frontline that have a platelet count of under 50,000, but if so, surely consider this. The fourth JAK inhibitor is on the cusp. It is seeking approval. And I had the honor of presenting the data from the phase 3 study just again at the ASCO meeting just about a week ago of this phase 3 study, momelotinib versus danazol in symptomatic and anemic myelofibrosis in patients that previously treated with a JAK inhibitor. Here, this JAK inhibitor also inhibits ACVR1. So this is the flip side to the hepcidin story. You heard earlier we were trying to mimic hepcidin to control erythrocytosis in vera. Here we try to decrease hepcidin through the inhibition of ACVR1 to try to improve anemia, improve erythropoiesis. There have been previous important studies with momelotinib. This JAK1 and JAK2 inhibitor, in addition to ACVR1, in the SIMPLIFY-1 study, which was the largest randomized study compared to ruxolitinib, it showed non-inferiority for control of splenomegaly. It showed rates of transfusion requirement. Momelotinib was superior to ruxolitinib. In improvement in symptoms, we saw about a roughly 30% improvement in myelofibrosis symptoms, both in SIMPLIFY-1, that upfront study, and SIMPLIFY-2 in the second line setting. It was slightly inferior to ruxolitinib as related to symptoms, but better with anemia. There was still felt to be a strong data gap in the second line setting to round out the registration profile for momelotinib, which was critical, so we designed the MOMENTUM study. Here, these were individuals that were symptomatic, they were anemic, they had previously been treated with a JAK inhibitor. So 195 patients were randomized in a 2-to-1 fashion, momelotinib plus placebo versus danazol plus placebo, with a momelotinib open label crossover with endpoints of total symptom score response and secondary endpoints of transfusion independence and splenic response. This study hit all of its endpoints. First, a clear improvement in symptoms, which was a primary endpoint compared to danazol. Second, a clear superiority for improvement in splenomegaly, whether one uses a cutoff of 35% or 25% volume reduction. This is the second-line setting. Indeed, we've shown in the past that a greater than 10% volume reduction in splenomegaly was associated with improvement in survival. For transfusion independence, the goal had been non-inferiority, but was really close to showing overt superiority over this active control arm. Rates of transfusion independence rose from 13 to 31% on momelotinib versus 15 to 20% on danazol. And you see here on the right, the really superiority of momelotinib, and then the kind of correction of the danazol arm up to momelotinib levels after crossover. In terms of toxicity, GI and some low-grade cytopenias. Again, so you're getting a sense many of these new agents do have some overlap in terms of toxicity. GI and watching the counts tends to be a recurring theme. The study was not designed as a survival study, partly because of the period of observation, the need for crossover. That being said, there certainly is a strong trend toward improvement in survival of momelotinib versus danazol. And this is despite the fact that there was a bit of an imbalance of death due to COVID. So this study completely accrued during the time of COVID. It started accrual in April of 2020, and particularly during 2020 pre-vaccination, there were 6 deaths on the momelotinib arm and 1 on the danazol arm. We certainly have not seen, after things have kind of normalized in the COVID world, that there has been any significant issues. So a lot of issues pre-vaccination. Certainly JAK inhibitors and COVID have been found to have some interaction, particularly in the pre-vaccine setting. There is some data that danazol may actually have some protective effect against COVID. These data build on some of our prior observations that there may be a survival advantage, and that survival advantage may be tied to an achievement in transfusion independence. Indeed, from the SIMPLIFY studies, this was an analysis that previously presented that's being considered for publication as we speak, or it's in press as we speak. You see here the difference in survival. So how do the JAK inhibitors fit together? Well, one, if we think about the spectrum of myelofibrosis patients requiring therapy, greater than symptomatic low risk. If you have proliferative frontline, ruxolitinib is still our cornerstone in hopefully an appropriately dosed fashion. Second line, proliferative, fedratinib. If you have cytopenic myelofibrosis, pacritinib is your frontline option, particularly if the platelets are under 50,000. I think if momelotinib becomes approved, I think there will be some delineation between patients where anemia is the main driver and a consideration will be momelotinib, or whether thrombocythemia is the main driver and it'll be pacritinib. Now, excitingly, there are new JAK inhibitor, non-JAK inhibitor mechanisms of action. The last patient I saw today, and indeed I saw and raced home to give this talk for you all, was to put a patient on a non-JAK inhibitor mechanism of action clinical trial. And these are exciting to see these rolling out. Indeed, there is an unprecedented number of alternative targets being looked at, usually with or without JAK inhibition, as kind of a cornerstone. Cell cycle checkpoint, anti-fibrosing agents, other signaling tyrosine kinase inhibitors, agents looking at the apoptotic pathway as they've been successful in MDS and AML, other immunomodulatory drugs, or a range of things that are epigenetic modifiers. So let me start with the first. This is in the MANIFEST study. This is with the BET inhibitor pelabresib. This has created quite a bit of excitement. And these slides were just presented just again a few days ago by my colleague Claire Harrison in Vienna, for those that have the opportunity to attend. Again, it has been felt since the beginning of the rollout of this agent that the combination of both BET inhibition and JAK inhibition may be beneficial, and that there's a synergistic effect in the combination of these two agents. The MANIFEST study was a study designed when the agent was with Constellation. The agent is now with the company Morphosis, but with multiple arms that can to evaluate a variety of scenarios, either alone as monotherapy, in combination is either frontline or as an add-on or as a second line. So multiple different approaches, of which the one that I think has gotten the most excitement and really captured the imagination is the thought of two drugs from the get-go in JAK inhibitor naive patients to optimize response. And these are the data that Professor Harrison shared with us in Vienna, which showed very significant responses in terms of splenomegaly and in terms of symptoms. Indeed, you see here in this waterfall plot that the vast majority of patients had significant reduction in splenomegaly, and that SVR35 at any time was 80% of the patients, with 69% maintaining it at the time of data cutoff. And likewise, the median total symptom score change was an improvement of 60%. So these are really some of the very best data we've seen to date for a combination approach for therapy for myelofibrosis. Here you saw, again, individuals that had a suboptimal response to ruxolitinib. When you add in the other agent, again, achieving good response in arm 2. You see here in arm 3, the combination leading to durable improvement in that spleen volume, both in the frontline setting on the left and in the add-on strategy on the right. These data do tend to suggest that there may be advantages to using the combination upfront versus waiting for an add-on approach. Side effects, again, there's a theme here, cytopenias and GI. So these, again and again, do seem to be a recurring theme in terms of side effect with new medicines in MPNs and need for management. Again, as one looks here, arm 2, very similar in terms of the spectrum of toxicities. Interestingly, there were a series of correlative studies that were also presented that showed the potential of some improvement in fibrosis for these individuals, and they are currently using new digital pathology mechanisms to further interrogate these data. And there was also some correlation of improvements with some other digital pathology measurements as related to fibrosis, as well as other histologic changes that could be assessed through digital pathology. All of this has led to the MANIFEST-2 study, which is actively accruing as we speak. Certainly would strongly consider anyone that's watching this, if you have a patient that is a candidate for JAK inhibition, newly diagnosed with myelofibrosis, consider the MANIFEST study before they begin on JAK inhibition. So this is for JAK inhibitor naive patients. Rux versus Rux plus pelabresib. The second agent, and there's many, but I'm just highlighting a couple, is navitoclax. This is a cousin of venetoclax. This works against BCL-XL. Indeed, it's been known for a while that there can be apoptotic resistance in myelofibrosis. Indeed, a million years ago, this was the subject of my NCI award when I was in the lab of Dr. Scott Kaufman. And indeed, it's gratifying to see this kind of come full circle with a therapy targeting BCL-XL. Francesco Passamonte presented some updated data. Like the MANIFEST study, there were multiple cohorts, and they presented at EHA the cohort of individuals that were JAK inhibitor naive. And here very specifically, both JAK and BET inhibitor treatment naive to not confuse matters. And they were started on navitoclax plus ruxolitinib with, again, improvements in splenomegaly and symptoms. In terms of toxicity, and there were a range of low-grade toxicities, but overall the investigators felt the drug was well tolerated. Potential of cytopenias and GI side effects, again, should not be a surprise. Thrombocythemia perhaps being a bit more represented. Here you see reduction in splenic volume. And again, with 63% of individuals achieving a spleen volume reduction under 35%. On the right, you see the durability of those response. And then you see here about a 41% improvement in symptoms. And again, this is in a single arm phase 2 study. So the numbers are small. And it's also very difficult, I'd say, to compare these data versus the data I showed you again from the single arm phase 2 of Manifest. I do think the phase 3 study are going to be looked at very carefully. They're not going to be randomized between each other, but I think with those numbers and power, we may get a better sense of, how do these things look like side by side. Some improvement in fibrosis. And again, I think the evolving mechanisms with digital pathology will be helpful in sorting out these data. We're at an unprecedented time with the greatest number of phase 3 trials ongoing in myelofibrosis, truly ever, in a recognition of advances in the disease. So one, there are drugs where we're looking at truly for individuals that have failed JAK inhibition. There's currently a telomerase inhibitor trial with a imetelstat that is ongoing as a second-line therapy with survival as the primary endpoint. There are the add-on studies. Luspatercept to help to improve anemia, that's ongoing and accruing. Would recommend you consider that for that TGF-beta ligand trap and help to improve anemia along with ruxolitinib. Navitoclax, which I mentioned, parsaclisib, PI3 kinase inhibitor from Incyte that's active and may help to add to the benefit of JAK inhibition, and the MPN inhibitor from Kartos. There are the combination studies in JAK inhibitor naive patients. Pelabresib, which I mentioned, Manifest-2, navitoclax combination, and the PI3 kinase inhibitor. So again, a robust pipeline of studies. Again, if you have patients with myelofibrosis, certainly be considering, if things aren't going ideally, should we consider a clinical trial? And if they're JAK inhibitor naive, consider one of these, because they're going to get ruxolitinib as the control arm or in combination in these, and we hope that these are incrementally better. So how do we help put all this together before we pivot to some time for some Q&A? Well, first, in patients where transplant is not selected, I think in low-risk individuals, we're going to be thinking about, one, if they're not symptomatic, observation or pegylated interferon. If they are symptomatic, ruxolitinib or a clinical trial. Again, with all those JAK inhibitors, only ruxolitinib has really been used in lower risk disease. In individuals that have a platelet count under 75,000 in intermediate to high risk, pacritinib. If they're anemic, myelodysplastic, or perhaps a combination, ruxolitinib plus luspatercept, ruxolitinib plus pelabresib. Or if they have standard myelofibrosis, normal counts, probably still ruxolitinib or fedratinib. There will be a subset at a minimum that I think we will identify. Benefit from combination therapy upfront, rux and pelabresib or navitoclax or parsaclisib or another. I do think the data from the phase 3 will be important to identify. Is that everyone? Is that a subset? Patients with a platelet count less than 50,000, pacritinib. Second line, if the spleen is a major issue and the counts are okay, fedratinib. Anemic, myelodysplastic, or again a combo. An increased risk, again, I think it'll go back to those combination approaches. Accelerated or blast phase, this is a tough group of patients. Some sort of enhanced induction. 7 and 3 doesn't really cut it in these patients, not very well. So if there's a target, use a target, consider a trial. No transplant, Rux plus a targeted therapy, if there's a target, is both the ongoing efforts in clinical trials and hopefully beneficial. If you fail frontline therapy, I don't think there's really a lot of rationale for second-line therapy in this group of individuals off study. I think a trial or support the survival in secondary AML from MF is very poor. And if there's not really a transplant in sight, I would be very judicious about therapy. How do we bring this to really precise and personalized cancer care? Well, I think we've learned a lot more about the clone, but there's a lot more to having a disease like this than just the clone. It's got to live in a person who has all these other issues, their risks, their comorbidities, and other medications. How do we weave together all of the factors to try to come up with the best treatment plan for really what is a chronic disease that we're trying to make a great impact upon and work in a shared decision-making model with our patients? With that, I very much would like to thank many individuals, clearly the tremendous MPN community. One of the things that's been very rewarding about being in this community, tremendous patient engagement, wonderful investigators, people very generous of their time and eager to collaborate. It truly is a wonderful space to be involved in, and some wonderful organizations that really have helped to make tremendous support: the MPN Research Foundation, the Keynote Lymphoma Society, MPN Advocacy Education International, the MPN Education Foundation, and many others. And certainly many wonderful friends and collaborators. Working in teams is one of the exciting things we all get to enjoy as being in academic medicine. And with that, again, my thanks for the invitation.